All right, good morning, everybody. This is the refresher course lecture, Anesthesia for Complex Spine Surgery. I'm Dr. Laura Hemmer from Northwestern University. Can you hear me okay back in the back? Great. All right, during this time this morning, we'll identify anesthetic considerations for adult patients undergoing complex spine surgery. I'll discuss perioperative morbidity with a focus on strategies to hopefully improve patient outcomes. It seems like the number and complexity of complex spine surgeries is ever increasing. I did a neuroanesthesia fellowship, so I kind of signed up, I guess, to do these cases. But even if you didn't per se sign up to do these cases, it's very likely that you do find yourself doing some of them. After all, most neuroanesthetics are conducted by generalists. And these cases include long operating times, prolonged prone positioning, and patients often have multiple medical comorbidities, and they face significant cardiopulmonary stress secondary to the major blood loss, fluid shifts, and transfusion requirements required during these surgeries. Our familiarity as anesthesiologists and our appropriate anticipation of potential problems with these cases can hopefully lead to a decrease in complications and improve outcomes. Not surprisingly, these technically and physiologically demanding surgeries are associated with pretty high perioperative morbidity. Numbers listed are all over the place in the literature. The best I could nail down for major complication rates, somewhere around 44%, and the mortality rate approaches 1%. That would be for all-cause mortality within 1 year postoperatively. If you include more minor complications, it's north of greater than 55%. This is a retrospective review from a prospective database evaluating adult spinal deformity surgical patients at 11 high-volume United States centers. It's not particularly large, but it does a nice job of breaking down the types of complications these patients face. They found that the incidence of patients with at least one medical complication within 6 weeks was 27%, and highlighted here the biggest category of complications, more than half the patients who did have a complication, was cardiopulmonary in nature, followed by infectious in nature. Data from the National Inpatient Sample, that's the largest all-payer inpatient database in the United States, found that the presence of several diseases is associated with increased mortality risk in spine surgery. The ones with the highest increases in risk for mortality I highlighted, that's pulmonary circulatory disease, congestive heart failure, renal disease, and coagulopathies. This study was particularly valuable because it highlighted pulmonary hypertension and right heart failure, which previously had been less well documented as mortality risk factors for these surgeries. Most complex spine surgeries are elective, and so they do allow time for preoperative assessment. And here a multidisciplinary team approach is critical. It allows for thorough evaluation and optimization of comorbidities. It provides for risk stratification. This is important not only for true informed consent with the patient and discussion with their families, but also the surgeon, it provides information to the surgeon. You know, he or she may decide not to offer such an extensive surgery to the patient. It allows for consideration and planning for social and environmental factors that can impact their recovery, and allows for patient counseling to set realistic postoperative expectations. There is indication in the literature that indeed a multidisciplinary team approach for the preoperative time period leads to improved patient outcomes. Now, there's not a single perfect calculator for high-risk spine surgery at the current time. The revised cardiac risk index, which is widely used, in general actually poorly predicts cardiac risk in multi-level spine fusion surgery patients. We found that in our own patients, it performed no better than chance in identifying our patients who experienced cardiac morbidity. Since then, there's been external validation in spine surgery of 3 online predictive tools. These are all free. They're listed here on the right side. One is SpineSage, that's from University of Washington. It was designed from a prospective database for spine surgery, and it has been shown to have the best performance in an external validation sample. More widely used, though, but not spine-specific. From the large nationwide standardized surgical database is the American College of Surgeons National Surgical Quality Improvement Program calculator. You probably know that as NSQIP. And then there's the risk assessment tool. It's developed and validated at a single center with spine database information, and it also has been shown to predict adverse events after spine surgery well. Now, as I showed on that prior slide, major cardiac complications are amongst the most common complications. So we need to evaluate carefully the cardiovascular risk. This will help identify patients who may benefit from intensive coronary artery disease risk factor management and or other cardiac optimizations, say improved blood pressure control. In patients with poor functional status, where the American College of Cardiology and American Heart Association guidelines suggest a stepwise approach for provocative testing, we'd recommend cardiac functional imaging, so something like a stress echocardiography, because that will provide not only a risk assessment for ischemic heart disease, but it will also allow for evaluation of right ventricular and valvular function and give information about the presence of pulmonary hypertension. Remember that other slide that said those were risk factors for increased mortality. The serum biomarkers for cardiac risk production can also be very valuable. We're talking about the natriuretic peptides here, and these have been shown to help identify patients at increased risk in spine surgery. It's also recommended to consider incorporating a preoperative high-sensitivity cardiac troponin T along with the BNP. That's been shown that the combination can provide even better predictive info for patients undergoing major non-cardiac surgeries. You may have noticed in just this month's ASA monitor, Dr. Sessler wrote regarding BNP that this test is inexpensive, available on a point-of-care basis, and probably should be used far more often than it currently is. Preoperative assessment for spine surgery could be a whole lecture in and of itself for the hour. So just to highlight some other key areas for emphasis: respiratory assessment and optimization, including a pulmonary evaluation if necessary, remembering that if the patient has significant thoracic spinal deformity, they may have a restrictive respiratory physiology. Of course, good control of blood glucose levels in diabetic patients, smoking cessation and alcohol and substance abuse counseling, nutritional management, including a dietary consult if patients are malnourished, weight loss counseling, and mental health. The ones with an asterisk there are specific Class 1 recommendations from the SNAC Clinical Practice Guidelines for Complex Spinal Instrumentation Surgery from 2022. If you haven't heard the term patient blood management yet, I predict you will be soon. It's getting more and more attention in the literature, but really goes back to at least about 15 years ago when the World Health Organization started noting that it should be a standard of care to improve patient safety and outcomes. And just this year, Hoffman and al. Wrote that blood is the most neglected organ. So it's important to pay attention to preoperative anemia in our patients with iron supplementation or erythropoietin stimulating agents where indicated. And normally when there's not clinical concerns for coagulopathy or bleeding, unselected coagulation tests preoperatively are not very useful. But in spine surgery, where the risk can be so high, you may consider them. Abnormal PT, PTT, and platelets have each been associated with increased intraoperative transfusion needs, reoperation risk, and mortality. Other laboratory preoperative assessment would include renal and hepatic function, and then also consider in our patients with degenerative spinal disease, do they have other coexisting musculoskeletal conditions? It's much better to figure out before the patient's under general anesthesia what their range of motion is. Advances in anesthesia and surgical techniques have allowed our elderly and potentially frail patients to undergo neurosurgical procedures that wouldn't have been offered to them in the past. This, coupled just with the world's aging population, means we need to focus on frailty as a potential modifiable characteristic. There's still a paucity of literature about how much prehabilitation does. Some of the literature is currently conflicting for spine surgery, but it will also give has implications for risk stratification and further clinical decision making. Part of the confounding factors with frailty may be that the functional impairment related to their need for spine surgery, the neurologic pathology, may be actually contributing to their frailty. So in an observational study of operative and non-operative adult spinal deformity patients, the frailty scores were found to improve in the post-operative group. It seems that frail patients will have more short-term adverse events after major spine surgery, but that their long-term improvement in patient-reported outcomes and quality of life is there. As far as frailty assessment tools, there's one that's specifically validated for adult spinal deformity. Unfortunately, its clinical use is rather limited. It has 40 different binary variables. Much more commonly is the Modified Frailty Index. That's comprised of 11 preoperative comorbidities, and it's the one most often used in the spine surgery population. There's a shorter one, a 5-factor one. There's the Clinical Frailty Scale. That one's easy to use, practical, has excellent clinical predictive value, and it's one of the recommended frailty tools. And actually, several of these here, the Modified Frailty Index, the Clinical Frailty Scale, and then also just Basma Mohammed and colleagues just this year recently validated the Fried phenotype also for lumbar degenerative spine surgery, and they found that that one had a little bit better performance even than the Modified Frailty. The ones the Frailty Index, Clinical Frailty Scale, and the Fried ones are also ones that are specifically recommended as frailty tools in the new ASA advisory for perioperative care of older patients having inpatient surgery. Okay, so we've gotten past the preoperative assessment. Our patient is ready to come to the operating room. We need to be thinking about our intraoperative monitors and access planning. Of course, routine basic physiologic monitors are indicated. The ASA standard monitors, as well as invasive blood pressure monitoring, is indicated for both continuous blood pressure assessment and to facilitate blood draws for labs. We'll want to ensure large bore intravenous access is obtained that we're very comfortable with before positioning prone. You know, when the residents call me the night before these big cases, they'll be like, we need 2 good IVs. I'll make sure that we have an 18 gauge and a 16 gauge before we flip prone. And I'm like, oh no, if that's all we can find for peripheral access, we're going to need to do a central line, you know, remembering what a difference there is in your diameter of the catheter and its flow rates. Central venous access is not usually indicated as long as you have adequate peripheral IV access, or unless there's other special patient considerations as far as their cardiac, as far as their morbidities that would make additional cardiac monitoring desirable, and or if you anticipate the need for postoperative vasopressor use. Now, even in the patients not coming for cervical spine surgery and patients with degenerative diseases of the spine, we need to be assessing for evidence of cervical spondylosis with cord compression. This would include myelopathic signs and symptoms by history and physical exam. It includes a neck evaluation for their range of motion. That's a pretty nonspecific sign, though. And review any available cervical spine imaging. Severe cervical stenosis can be present without any clinical signs and symptoms. A review from ASA Closed Claims database shows that cervical cord injury can occur despite an anatomically stable spine. That's what we're talking about most often for these cases, and that degenerative cervical spine disease is the underlying condition that may most often predispose patients to risk of airway management cervical cord injury in the absence of instability. There's not really any outcome data to support any particular method. After all airway maneuvers and airway management devices will lead to some cervical motion. The overall take-home point for this is that the technique chosen should reflect clinical factors and clinician expertise, whatever you think is most likely to be effective on the first attempt in your hands, and use of spine immobilization during airway management has become standard of care, at least in the setting of instability. You know, if you're really worried about the cervical spine and the airway, I would advocate for a fiber optic intubation. It's the one that does indeed cause the least cervical spine movement. Awake fiber optic intubation with topical anesthesia not only allows for the head and neck to remain in neutral position, it also maintains protective airway reflexes and allows for a neurologic exam post-intubation. You can find in the literature lots of references that it's considered the best method to cause minimal movement of the cervical spine, the best method, the preferred technique, etc. There is not a difference, though, between awake versus asleep fiber optic intubations in terms of neurologic outcome. That's based on retrospective reviews in cervical spine injured patients. With the popularity of indirect laryngoscopy, it's been compared in multiple studies to direct laryngoscopy. It's at least equivalent, if not leading to decreased cervical motion. It certainly does improve the glottic view. Romito et al. Analyzed movement of a maximally destabilized cadaveric cervical spine and head fixation device. They found no significant difference in motion between 3 commercially available video laryngoscopes. So choose whichever one you have at your institution or that you're most familiar with. But each one did elicit less motion than direct laryngoscopy with a Macintosh blade. Of note, other studies have also found that there's not a significant difference between different types of direct laryngoscope blades, so use whichever one if you are doing direct laryngoscopy, whichever one is your favorite. In a study comparing awake video laryngoscope intubation with awake fiber optic guided intubation for cervical spine movement in adult patients undergoing surgery for C-spine instability, they found that the C-spine motion was greater with the video laryngoscope than fiber optic intubation at C1, C2, but no difference at C3. Those were their assessed levels. They didn't have any new onset motor deficits in any of the patients. And this was what was most interesting to me since the patients were awake. They did not find a difference in patient satisfaction or hemodynamic parameters between the techniques. Now, you can't think about spine surgery without thinking about intraoperative neuromonitoring. It's an integral part of these surgeries to provide continuous assessment for neurologic tract integrity. It allows for corrective action, hopefully, before a neurologic insult results in permanent damage for the patient. Usually this is going to be in the form of multimodality monitoring, as this will improve sensitivity for detecting neurologic system trespass. The modalities we're talking about for spine surgery would be combined somatosensory and motor evoked potentials. These offer the ability to monitor both the ascending dorsal column medial lemniscus pathway and descending cortical spinal tracts, respectively. And then electromyography, EMG, both spontaneous and triggered, is combined in usually to better detect nerve root injuries. Evoked potentials are going to detect spinal cord injuries better, and nerve root injuries will be better predicted by EMG. You don't have to be around cases that involve neuromonitoring for very long to know that anesthetics and anesthesiologists are frequently blamed for problems with the monitoring. And it's true, our anesthetics do impact evoked potentials. They impact the synaptic function more than neuronal conduction. So what you'll see is more of a decrease in the amplitude rather than an increase in the latency. The impact of anesthetic agents on neuromonitoring increases with the number of synapses involved in the pathway. For completeness sake, I included visual evoked potentials here. Usually we would not be using those for spine surgery, but those will be the most impacted. Of relevance for us for the spine surgery cases would be transcranial motor evoked potentials are next most impacted, then somatosensory evoked potentials when they're being recorded cortically, which is where they're being recorded primarily. That's what we're talking about when there's a change, usually as at least the first discussion. And then less impacted would be brainstem auditory evoked potentials. Again, not usually used for spine surgery, though. Once the planned neuromonitoring modalities are known for the case, if you tailor your anesthetic maintenance regimen for the modality that's most sensitive to our anesthetics, in general, that will work out for the other modalities also, with consideration for patient comorbidities and any other surgical requirements. So usually we're tailoring our anesthetic regimen for transcranial motor evoked potentials for spine surgery. Now, usually we're talking about our maintenance regimen when we're worried about the neuromonitoring, but sometimes for these cases we need to facilitate prompt motor evoked potential acquisition soon after intubation. This is the case where there's either spine instability or there's severe myelopathy, or we're just worried about our ability in the patient to be able to obtain good baselines. We want to see what they look like before we position prone. So in these cases, to facilitate that monitoring, short-acting muscle relaxant succinylcholine was ideal if it's not contraindicated. oftentimes if there's weakness present or other issues, it's going to be contraindicated in these patients. Aminosteroid neuromuscular blockade that can then be reversed with Sugamidex also works, although with consideration if that's going to complicate your future relaxation needs. After you position prone, you'll get your baseline signals that time. And then if it's a significant surgical exposure, the surgical team would likely appreciate some more neuromuscular blockade. So you'll want to consider that if you're going to be reversing with Sugamidex. You can consider alternatives that don't require neuromuscular blockade at all. High-dose remifentanil with propofol, keeping in mind the hypotension that would ensue and avoiding it, or an awake fiber optic intubation technique to avoid neuromuscular blockade. MEPs and or EMG will limit neuromuscular blockade use to only with facilitating intubation and perhaps during surgical exposure. After that, we won't be using neuromuscular blockade. Of course, when they're doing transcranial motor evoked potentials, don't forget to pay attention to the bite block. It stimulates the muscles of mastication. You don't want a bite injury. So you want a soft but firm bite block between the molars. Place that before they start acquiring signals. Double check that it's still there. It doesn't do any good if it's on the ground after you've positioned prone, and paying attention to be checking periodically throughout the surgery. Okay, this is actually a graph that I use and that I have in my head all the time when I'm approaching these cases. We get blamed as anesthesiologists and with our anesthesia for problems with the neuromonitoring all the time, but sometimes it's just the patient factors. One of the big ones is pre-existing muscle weakness. So this is a study from Lanjun Gao, and she looked at patients who had thoracic spine cord tumors. They considered what the strength was preoperatively in the lower extremities, and then what their ability to get good, reproducible, monitorable baselines was in the lower extremities using a facilitating TIVA technique and no neuromuscular blockade after intubation. And in patients who were 5 out of 5 strength, you can see there on the right-hand side, they were able to get good baselines that were able to be used for the case in everybody. 4 out of 5 strength, still pretty good, most of the patients. But look at that big decrease in success once you get to 3 out of 5 strength. If the patient's 3 out of 5 weakness, or perhaps even 4 out of 5, depending on other factors I'll go into, then I'm going to be on that side of starting with a very facilitating anesthetic technique. I'm an adult anesthesiologist, so thinking about the decades of life between a patient in their 20s to into their 80s, you will see longer latency and smaller amplitudes for both MEPs and SSEPs as patients age. MEPs are more impacted, but you'll get about slightly more than a 30% actual decrease in the motor evoked potentials if you compare a patient who's otherwise similar in their 20s versus their 80s. So that right there can be significant. Increased height and weight and lower extremity edema can make it hard to get somatosensory evoked potentials. Just think about the distance that edema, fluid, or subcutaneous fat can have between the stimulating electrodes and the nerve. Stephanie Diner found that diabetes and hypertension were medical factors that made it harder to obtain adequate baselines in spine surgery patients. Also peripheral vascular disease, myelopathy we've kind of talked about, as well as other neuromuscular diseases can also make it harder. Diabetes, I think, intuitively makes sense, because of peripheral neuropathy. Hypertension maybe makes a little bit less intuitive sense until you think about the endothelial dysfunction that can occur, perhaps resulting in some vasoconstriction and chronic nerve ischemia. And then even if the patient is neurologically intact, if their MRI imaging looks bad, if they have a hyperintense signal on T2 weighted C-spine imaging, that has also been found to make it harder to get good baseline signals, and suggested to use a more facilitating technique to obtain baseline signals off the bat. So putting this all together, if I'm anticipating difficulty with obtaining adequate motor evoked potentials, I'd be over here on the right-hand side where I'm considering a TIVA from the get-go and no neuromuscular blockade. If the patient's neurologically intact, they don't have any of those other medical comorbidities, I'd be over here on the left-hand side perhaps, starting with a half a MAC of volatile agent, supplemented still with less suppressive anesthetic agents, and still no neuromuscular blockade. No matter which side you start with on the algorithm, you want to be in contact with the neuromonitoring team as they're getting their baselines to know what those signals look like. If I'm on that left-hand side and I'm surprised the signals actually aren't that great, you need to be ready to switch immediately to Ativa to get new baseline signals. If you were already on the right-hand side, you were worried about what the baselines are going to look like, and they're still not very good, then consider either, if you can, decreasing that hypnotic agent further, leaning a bit more on the opioid, and or perhaps adding another augmenting, facilitating anesthetic agent. I'll get into that in a bit. Now, not only do we want to be tailoring our maintenance anesthetic regimen for neuromonitoring, we want to be thinking about postoperative pain. Spine surgery hurts. A large prospective multi-center analysis of pain intensity on postoperative day 1, following a wide slew of different surgeries, 179 different surgical procedures. Median pain scores were second highest in patients undergoing posterior spinal fusion. 3 of the 6 surgeries with a median pain score on the numeric rating scale of 7 were major spine surgeries, and pain treatment after spine surgeries ranks commonly insufficient. Postoperative pain control is particularly challenging in these patients because pain is coming from activation of multiple different pain components. There's nociceptive, there's neuropathic, inflammatory, and spasmodic mechanisms all at work. Further confounding the problem is if patients are on preoperative opioids, as that will make postoperative pain control requirements even harder. So it's common to focus on multimodal analgesic approaches in order to target pain control on these different pain mechanisms. No improved outcome is shown for any specific anesthetic agents, however, so therefore the SNAC guidelines actually currently do not recommend any specific multimodal analgesic approach. This is a whole other hour-long topic if we wanted it to be, so I will refer you to this excellent article, Dr. Shobana Rajan and colleagues and JNA in 2022, which focused on non-opioid alternatives for postoperative pain and spine surgery. It covers preemptive analgesia, perioperative IV adjuncts, neuroaxial blockade, regional nerve blocks, and other local anesthetic options. Of course, being mindful that with neuromonitoring, some of the neuroaxial blockade regional nerve blocks will hinder that monitoring. I like this pictorial from Anesthesiology. It's in reference to a study from Maheshwari et al. This is from 2020, I think I said. That was a randomized spine. That was a study that was randomized spine surgery patients at high risk for postoperative pain. They implemented a multimodal regimen compared to placebo. Each agent that they included has other studies that were supportive of its use and effectiveness in spine surgery, but this was a bigger study where they put them all together. So it was acetaminophen and gabapentin preoperatively, and then lidocaine and ketamine infusions intraoperatively. And unfortunately, the study was stopped for futility at 299 patients. They did not find any difference in quality of recovery, 48-hour opioid consumption, or pain scores. An alternative or additional approach could be IV methadone. Of course, we think of it as a very potent mu-opioid receptor agonist with a long half-life, but actually it is multimodal in and of itself. It also has action as a non-competitive partial antagonist at NMDA receptors, and it inhibits monoamine, serotonin, and norepinephrine uptake. That can come into play for a patient's mood postoperatively and then impacts how they manage pain. Dr. Glenn Murphy performed a parallel group, randomized, double-blinded, placebo-controlled trial assessing postoperative analgesic requirements in posterior spinal fusion patients receiving IV methadone, 0.2 milligrams per kilo at the start of surgery, or hydromorphone 2 milligrams at the end of surgery. Other studies have shown those to be pretty equivalent opioid equivalent doses. 115 patients, study groups did not differ in any preoperative or intraoperative characteristics. The primary outcome was IV hydromorphone requirements on postoperative day 1, and the methadone group actually was found to have significantly decreased postoperative analgesic requirements, decreased pain scores, and a favorable perception of their pain management. No difference in side effects or risks was appreciated. Potentially adding ketamine has further beneficial effects with methadone. This is thought to be since both agents have NMDA receptor antagonist activity. A recent scoping review identified 2 randomized controlled trials. One by Dr. Murphy's group here is shown on the right-hand side, but 2 trials that examined methadone in combination with ketamine in spine surgery specifically, and they found that overall co-administration led to a greater than 50% decrease in opioid consumption compared even with methadone alone. We want to control acute postoperative pain not only for the patient's comfort and their ability to start getting mobilized in the first few days after surgery, but also because we know that acute postoperative pain intensity during postoperative days 1 through 3 is a major predictor of chronic post-surgical pain. And the highest incidence of chronic post-surgical pain is after complex spine surgery. So 55 to 60% of our patients report pain at 1 year postoperatively after these surgeries. So 1 intraoperative dose of IV methadone, that same 0.2 milligram per kilogram dose, has also been found in a different study by Murphy et al. To have an analgesic benefit that lasts 3 months post-spine surgery. So that may help attenuate development of chronic post-surgical pain. The idea here is finding preventive analgesics where there's anti-nociceptive intervention that's blocking development of a sustained pain throughout the perioperative period and then inhibiting that central neuronal sensitization that can occur. Anytime you're considering adding something new, multimodal, into the maintenance regimen, you want to reflect back to how that's going to impact the neuromonitoring modalities also. We reviewed the literature for the last 20 years, assessing how some of the common multimodal agents can impact evoked potentials. Remember when I mentioned of adding in another potential facilitating anesthetic, you can see here that ketamine's arrows go a different direction than the other arrows. And with its excitatory action, it actually can improve evoked potential signals. If you give too big of a bolus, 1 milligram per kilo, it has been shown to actually decrease your motor evoked potential, so you want to be careful with your dosing. But in more moderate dosing, it actually will facilitate the signals. Not only is our selection of anesthetic agents intraoperatively important, but obviously our hemodynamic management intraoperatively is of critical importance. Spinal cord perfusion pressure equals MAP minus intrathecal pressure. You can see the analogy with cerebral perfusion pressure equals MAP minus ICP. And just like in the brain, spinal cord autoregulation maintains a constant blood flow between a wide ranges of mean arterial pressures. The autoregulation lower limit, though, has significant intra and individual variability, partly depending at least on comorbidities. In general, a good goal is to maintain MAP greater than 55 in patients with spinal cord compression. That comes from spinal cord injury literature, and then otherwise to maintain normal tension in our patients. If you've been doing this a while, you may remember the days of induced hypotension for major spine surgery. That is kind of a thing of the past. This is a summary of meta-analysis results from 42 studies evaluating the relationship between blood pressure cutoffs and adverse patient outcomes, including mortality, after non-cardiac surgery. And you can see that the risk, the odds ratio increases as the mean arterial pressures decrease. Blood loss is a big consideration in these cases, with estimated blood loss reported to range between 1,200 to 11,000 mils for adult spinal deformity surgery. It's multifactorial in nature. Part of it's just the exposed bony surfaces are not amenable to standard hemostatic maneuvers that would be used for soft tissue surgery. And then another is from the increased abdominal pressure from prone positioning that translates to increased pressure in the epidural venous plexus, adding to increased intraoperative bleeding. That's essentially where the idea for induced hypotension originally came from, that they were trying to decrease epidural venous plexus bleeding, but really systemic blood pressures have very little to do with that. It is pressure from the abdomen, so you want to be paying close attention that the abdomen is free from compression during positioning, in a form of an open type table. Now, in helping to anticipate just how much blood loss is likely to occur in the surgery, right, 1,200 to 11,000 is a big range that would have very big different implications for what we're planning for the surgery. It helps if you know some of the abbreviations from the spine surgery alphabet. The format of this slide with the emojis I stole from one of my former residents and fellows who's now a colleague. That younger group tends to think in terms of emojis. Actually, one of our residents doing a poster at ASA, also in a completely unrelated poster, I noticed put emojis on his poster also for ASA, so they're really thinking in terms of emojis. But her emojis reflect how much blood loss you can be anticipating with each of these common abbreviations for spine surgery. So PCO stands for posterior column osteotomy, or SPO, that's Smith-Peterson osteotomy. What that means is they're removing some bone from the back of the vertebral arch. You can see that image at the top of the screen here. It produces about a 10-degree correction per level. They may do multiples of these to get more correction, and it's used to correct gradual levels of kyphosis. PSO stands for pedicle subtraction osteotomy. That's removing the vertebral arch and pedicles and part of the vertebral body. It leads to about 30 degrees of correction. You can see the emoji face changing there. And then vertebral column resection, VCR, removes entire vertebra and replaces it with bone grafts and cages. It produces about 80 degrees of correction, and that one's going to have significantly more blood loss associated with it. There are a couple calculators out to also help predict just what the blood loss will be. One is the predictive model of transfusion in spine surgery to determine the individual probability of erythrocyte transfusion in adult patients undergoing thoracolumbar spine surgery. Independent risk factors from this calculator are age greater than 50, pre-op hemoglobin less than 12, the number of levels being fused, and the osteotomy components. Remember the emojis on the previous slide. They found that a score greater than 2 on the calculator was highly predictive of transfusion of at least 1 unit during the perioperative period. However, that's over 5 days, and I don't think too many of us would be very excited about that if that was all we were talking about. This is a predictive model that we developed for calculating probability of major transfusion during the intraoperative time period for these surgeries. We defined it at that time as PRBCs greater than 4 units. It's based on the operation duration that's anticipated, the number of posterior levels being instrumented, a surgical complexity score, which is defined in the paper but reflects back to those osteotomy components that I was talking about, and the preoperative hemoglobin level. So our proactive management when we're expecting some major blood loss is important, and our management of any developing coagulopathy. So in addition to assuring large bore peripheral or IV access before we start, we want to ensure access to blood products preoperatively. Blood transfusion rates overall for these surgeries range between 50 to 81%. We'll be paying attention to the patient's core temperature, since that can help to minimize coagulopathy and therefore blood loss, keeping the OR temperature warm, and starting active patient warming and fluid warming early on. Blood salvage can be an important component of blood conservation strategies. A 2023 meta-analysis of randomized controlled trials, which involved greater than 14,000 patients, found that cell salvage decreased allogenic RBC transfusions in major spine surgery. The time to think about instituting it preoperatively is if you're anticipating blood loss about over 750 mils and that you're anticipating that will necessitate allogenic blood transfusion, assuming that the case does not involve infection or cancer. If you do have cell saver, you might as well use it to help also quantify your blood loss. It's helpful with that. I like the term blood loss prophylaxis, which is from Mullen et al. Part of that is antifibrinolytic use. The SNAC guidelines indeed do say that the use of IV antifibrinolytics are indicated in complex thoracolumbar spine surgery. The lysine analog tranexamic acid is the one that's most commonly used, but dosing is not standardized in major spine surgery. Lower doses may decrease transfusion about as much as higher doses and may decrease postoperative transfusion requirements. A meta-analysis of TXA in spine surgery reported significantly less perioperative blood loss than placebo and no increase in thromboembolic complications. Much more reassuringly, Mullen et al. Assessed patients who had specific pre-existing thromboembolic risk factors, and that in a multi-center assessment. And they also found for patients undergoing adult spinal deformity surgery no increase in postoperative thromboembolic events with TXA use. Previously, all those other studies that weren't finding increased risk of thromboembolic complications, when you really read them, a lot of times they'd actually actually excluded patients who were at higher risk. So this study was very reassuring. Another component for blood loss prophylaxis could perhaps be the synthetic vasopressin analog desmopressin. Desborough et al. Performed a systematic review and meta-analysis in cardiac surgery studies and reported that 0.3 to 0.4 mics per kilo IV desmopressin leads to lower blood loss and no difference in thrombotic events or all-cause mortality. Wang et al. Performed a systematic review and meta-analysis of randomized controlled trials using desmopressin in cardiac and non-cardiac surgeries and procedures, and found that it may be an additional, and concluded that it may be an additional strategy along with TXA to reduce bleeding and transfusion. There may be some additive or even synergistic therapeutic effects there. And also do consider it in patients with renal disease who may have uremic platelet dysfunction. We'll be following labs frequently for these cases. It'll help us, not get behind, be surprised by blood loss, help us actively manage these bleeding patients. Labs would include ABG with electrolytes and whatever you call your emergency hemorrhage panel, but including PT, INR, PTT, fibrinogen, and platelets. During really massive bleeding, consider point of care testing, so thromboelastometry, to further assess hemostatic function. Of course, it's not all blood products. We'll be using fluids also to maintain preload during intraoperative blood loss. Balanced crystalloid solutions are recommended as they'll lead to less hyperchloremic metabolic acidosis and decreased risk of AKI compared to 0.9 normal saline. You will, however, want to minimize balanced crystalloids that are lower tonicity because of concern for soft tissue swelling and spinal cord edema. A propensity score matched analysis of patients undergoing multi-level thoracic and or lumbar spine fusions found that increased administration of crystalloid to colloid ratio, so more crystalloid, was independently associated with delayed extubation, presumably because of edema concerns. And they said you should have a low threshold for using colloids rather than high volumes of crystalloid to maintain intravascular volume in the event of large blood loss associated with multi-level spine fusion surgery whenever possible. Fluid resuscitation is guided much the same way we do this with any surgery: heart rate, blood pressure, acid-base status, lactate level, estimated blood loss, urine output, and pulse pressure variation. However, pulse pressure variation is a bit different when you're prone. In spine surgery, where a positive pulse pressure variation of 11 to 13% predicts an increase in cardiac output in response to a fluid bolus, a higher volume threshold pulse pressure variation of greater than 15% is what predicts volume responsiveness in the prone position due to the change in hemodynamics. I don't usually wait. You don't really want to wait till you're at that 15%, particularly if you're heading into the time period where there's osteotomies that are approaching that sort of thing. I'm going to be watching the trend and acting on that before I actually got to 15%. Oh, and also to note, that's with tidal volumes of 8 to 10 mils per kilo, and most of us are not ventilating our patients with that high of tidal volume. So again, that hard number of 15% is not really what we're waiting for. Okay, vasopressors are also usually included to meet MAP goals. That's pretty routine. We can't keep flooding these patients with fluid. There's not currently specific recommendations for specific vasopressor therapy in spine surgery. Currently, vasopressor selection depends on the hemodynamic conditions of the patient, of course, but also just plain old physician preference and institutional routine. Dr. Ehab Farag et al. Performed a retrospective cohort study of adult complex spine surgery patients. They reported that intraoperative vasopressor infusion with phenylephrine did not lead to a change in glomerular filtration rates and was not associated with increased odds of augmented acute kidney injury stage. And they said tolerating hypotension to avoid vasopressor use would probably be a poor strategy. As far as when to start transfusing RBCs, you can use kind of a dynamic transfusion trigger. So considering the patient comorbidities, the amount of current and anticipated ongoing bleeding, so depending on where we are in the surgery, and considering if you are using cell saver where you are with that. It's a shame to give an allogenic unit and then be handed a cell saver bag. The American Association of Blood Bank, actually I think they recently changed their they have the same acronym, but they changed what they stand for. Can't remember what the new one is, but the AABB guidelines for hemoglobin transfusion threshold is 8 grams per deciliter for orthopedic or cardiac surgeries, as well as in patients with cardiovascular risk factors. But, here consider the clinical context. It may be reasonable to have a little bit higher threshold if you're about to start a higher blood loss portion of the surgery. It's routine in neurosurgery to maintain the platelet count greater than 100,000. That lacks strong evidence, but where the risk could be catastrophic for neurologic complications, that's what's usually done. And then, of course, I mentioned desmopressin on that prior slide. Consider it as a possible adjuvant to improve platelet function if the actual numbers are okay. Cryoprecipitate is an excellent low-volume alternative to fresh frozen plasma to treat hypofibrinogenemia, which frequently develops kind of early on in these cases with bleeding. Will replete the fibrinogen, help with hemostatic control, and it has been shown to decrease overall blood loss and transfusion in spine surgery. I almost never give FFP in these cases. I very frequently am transfusing cryoprecipitate, sorry. All right, so as we're approaching the end of surgery here, we're still paying close attention to continued blood loss. This will still occur as the wound is being closed. There's output from the drains. What happens, unfortunately, sometimes is, they start this big closure. Maybe it's even a plastics closure. Now it's well into the evening. We're on maybe the second or third anesthesia team of the day, and they think, oh, great, labs were checked when they started closing. Nothing's happened since then. And the patient looks okay until they go to flip the patient over to at the end of surgery, and all of a sudden the patient's very hypotensive. And indeed, when labs are checked, the hemoglobin is now 5 or something. And it's because of that continued bleeding. People didn't recognize the need to be continuing to check labs during a long surgical closure. It's often routine to admit to the ICU environment postoperatively, although studies are lacking if such postoperative monitoring actually alters perioperative morbidity and mortality. We want to be gearing our anesthetic for prompt emergence to facilitate a neurologic exam, so any issues could be recognized and treated sooner rather than later. That doesn't mean we're necessarily extubating. That just means we're tailoring the emergence so the patients will follow commands. And tracheal extubation will happen after the patient's fully awake, following commands, able to manage and protect their airway, with significant attention being paid to airway edema concerns, especially after very long surgeries requiring large volume fluid resuscitation while we've been in the prone position. Consider a cuff leak test prior to extubation. When you're talking about cervical spine surgeries, especially if it's anterior and posterior procedures together, these will further predispose to increased risk of postoperative laryngopharyngeal edema and prevertebral soft tissue edema. Other predictors, just in anterior cervical spine surgery alone, other predictors of airway complications have been found if there's greater than 3 vertebral levels, blood loss greater than 300 mils, and if instrumentation was at the upper cervical levels. You can see here in this diagram, the purple one, pharyngolaryngeal edema, is of the most interest or concern to me on this one, because you can see that actually starts to occur, it's 24 to 72 hours afterwards. So that's after the time, even if this patient was in the ICU, they may be well onto leaving the ICU, long before we fully get out of that time period. So you do want to be counseling the patients on symptoms to be looking out for early on so that they can alert the team. Another special consideration in spine surgery is postoperative visual loss. This is fortunately a rare, but unfortunately a very devastating complication. It's most commonly caused in spine surgery by ischemic optic neuropathy. A multi-center case control study comparing adult patients with ischemic neuropathy from the ASA postoperative visual loss registry identified a number of factors related to increased risk. Those are highlighted there, but male sex, obesity, use of a Wilson frame are included. And then also interestingly, it's higher risk if there's lower colloid to crystalloid ratio. Perhaps that makes sense because of the edema that's occurring with crystalloid. The ASA practice advisory from 2019 regarding postoperative visual loss specifically says, quote, inform patients in whom prolonged procedures, substantial blood loss, or both are anticipated, that there may be an increased risk of perioperative visual loss. So we should be talking to some of our patients about this for sure. And then, of course, if there's any concern about visual deterioration afterwards, this is need for an urgent ophtho consult. I'll mention the Stagnera wake-up test. It's very rarely needed. I think I've only done this 3 or 4 times. I've kind of lost count, but ever. It's rarely needed these days in the setting of multimodal neuromonitoring, but if there is a question, this is 100% accurate when performed appropriately and the patient's awake enough to follow commands. If you need to wake them up intraoperatively to detect a gross motor deficit. Obviously, it's only giving you information at one single time point. And finally, a more recent focus is myocardial injury after non-cardiac surgery. That's MINS, the 2024 AHA, ACC, and a whole bunch of other society guidelines say, quote, myocardial injury after non-cardiac surgery is a newly identified disease process that should not be ignored because it portends real consequences for affected patients. Death in MINS patients actually is a leading cause of 30-day postoperative mortality, and if it was included in rankings, it would be the 3rd leading cause of death nationwide. So not just surgical related, but thinking about traumas and cancer, etc. And this is even for MINS patients without any ischemic signs or symptoms. That's 90%, about 90% of patients don't have any other signs or symptoms beyond a troponin elevation. So the guidelines say troponin surveillance may be reasonable in patients with known cardiovascular disease risk factors, and in patients undergoing high-risk surgery, that would be spine surgery, to identify patients at elevated risk of postoperative events. And then in patients who develop MINS postoperatively, especially in those not previously known to have excess cardiovascular risk, outpatient follow-up is reasonable but should occur for optimization of cardiovascular risk factors. And then they specifically say patients should be made aware of their MINS diagnosis during their surgical encounter. So to conclude here, a coordinated multidisciplinary effort throughout the perioperative time period is required to mitigate patient perioperative morbidity and mortality for these medically high-risk and complex surgeries. Close perioperative involvement by anesthesiologists familiar with these procedures and proactive in our management with anticipation of potential problems should help to decrease complications and improved outcomes. We want an emphasis on organized intraoperative communication and collaboration between the team members. That's an integral component for improving patient outcomes. Communication deficiencies are frequently linked with poor medical outcomes, and it has been shown recently that a higher surgeon anesthesiologist dyad volume in spine surgery, the more often we work together, actually leads to a reduction in morbidity. And then finally, consider staging longer surgeries, particularly when that surgery is associated with significant blood loss. All right, thank you very much. I'm happy to take questions. I've left my email here also if you think of anything afterwards or would like to ask a question, not in the big group format, but please do come up to the microphone if you have a question.
Fantastic talk. Thank you so much, Rafi. Talking about the timing of baseline you're monitoring and how soon should that be done, because it's right after induction when you're starting to do your lines and put the arterial line and everyone is rushing. Maybe that is a bit too soon because that's the effect of induction agents may be still there, as well as where your pressure is, have you started your ketamine yet or not? Have you started the other medications?
You're exactly right that actually there's a study going back a long time ago. I don't know if it would be able to be done these days, but 2 milligrams per kilo of propofol, right, our standard induction dose, impacts motor evoked potentials in patients who don't have any other background anesthetic going. That's why I don't know that this would be able to be completed these days. Motor evoked potentials, transcranial motor evoked potentials are pretty painful. If you, it has shown a degradation in the signals compared to baseline giving that bolus dose of propofol for the next 30 minutes. And so certainly the induction dose does play a role. I actually kind of tweak my induction dose oftentimes if I do need pre-positioning signals. Fortunately, most of the time otherwise, we have some time. If we're not getting pre-flip signals, we do have some time, because by the time we've induced, we're intubated, we have all of our lines in place. By the time we actually get position prone, that does buy us a bit of time. Please.
Hi, Stan Black from UNC. Thank you again. Great talk. I guess one way to figure out who's really enthusiastic about spine is Sunday morning 8 o'clock lecture. So here's your cohort. Just one thought. Thank you for mentioning methadone. I think there's still a lot of institutions that are very reluctant to use it. So at UNC, we are trying to get more people to use it, but we still have some holdouts who are just terrified of even the thought of methadone. So thank you for presenting that data. And also, I just want to draw the group's attention to Sandy Bay et al. Was from 2022 as a network meta-analysis on spine analgesia. So they found that paracetamol, NSAIDs, and then a third adjunct were kind of the biggest bang for the buck as far as like combination of drugs. Gabapentinoids was part of that, but kind of if they're already on it. But magnesium, alpha-2 agonist, and lidocaine. So we've started to use dexmedetomidine a lot for our spines and have had some pretty good results. I was just wondering if at Northwestern, if you all are using dexmedetomidine for your spines, if you have any comments on it.
Some of my colleagues do more than others. We are big advocates of methadone, so we do widely use it, obviously paying attention to patients who it wouldn't be appropriate in with QT prolongation, etc. Dexmedetomidine, while I use it in certain patients, it's not part of my routine. Part of that comes from the multi-center French randomized study where they were trying to avoid opioids and a big bunch of different types of major surgeries. And they actually stopped that study for safety concerns regarding bradycardia and asystole in the patients receiving dexmedetomidine. If you look at that study quickly, you'll see that there's a big range of doses that were used, and some of those doses you'd be like, well, I would never actually go that high anyway. But if you look further into it, the adverse effects actually were not, it wasn't linearly correlated, so a lot of those were occurring in lower doses that I would consider to be more commonly used. So it is something I consider in patients where I think it's a good choice for additional multimodal, but it is not my part of my routine. It certainly is part of the routine for a few of my colleagues, though, these days.
Good morning.
Good morning.
I'm a pediatric anesthesiologist, and back when I started practice about 20 plus years ago, there were epidural catheters. I think you mentioned a little bit on that. We used to place, actually the surgeon used to place two of them, one from the cephalad end, one from the caudal end. I'm talking about spinal fusions, upper T to lower lumbar area. And then had this catheter has multiple perforations. And I don't know whether that was helping, but would you make a comment on that?
These days, I think 25 years ago, they weren't doing the transcranial motor evoked potential monitoring. So if they're infusing local anesthetics through those catheters during the surgery, that's going to impede the monitoring. So that's a consideration these days as far as that. I see Dr. Shobana Rajan, who was the lead author. Dr. Avitzian's on that paper too. But those are your people to really talk to if you want more in-depth information about that. It's oftentimes hindered, though, by the neuromonitoring perspective these days.
Hi, this is Shobana Rajan from Cleveland Clinic. Excellent lecture. Thank you so much for this comprehensive overview. I was wondering about ESP blocks. I'm not sure if you mentioned and I missed it, but do you commonly use it for the regular spine cases? We've just started using it at Cleveland Clinic and we do think it gives good results. If so, what medications do you use and how do you use it?
We're not using them for our major spine surgeries, and part of that would be, if the surgeons wanted to do it at the end, that may be an option. But again, there are some concerns about the neuromonitoring. Are you doing it at the end of surgery or are you doing it beforehand? Beforehand, and you haven't had any issues with it?
We don't generally use it for the major neuromonitoring because we just have to do it at multiple levels.
Yeah.
And so maybe for like 2 or 3 level surgeries, we still do it.
Some of those blocks are some sporadic. I think the local must be tracking or something, but when it's been done preoperatively, it has hindered their neuromonitoring potentials.
Hi, good morning. Excellent talk. Mary Ellen Lopez as well, Cleveland Clinic. I have actually 2 questions. One is a very practical one. often our arterial line fails for complex spine, just because of the duration of it and because of the aggressive MEPs that has to be performed. So I was wondering what you do, to protect your arterial lines. So it's a very practical question. And my second question is, I love that idea of desmopressin as a preemptive medication as well with TXA. Do you do that at Northwestern? Yeah.
We've been, so to answer your second question first, we've been using desmopressin as part of a high-risk spine protocol since 2006. So we frequently, I use it in the situation one, just kind of off the bat if the patient does have CKD. Or maybe not off the bat, but I'll say to, my surgical colleagues, hey, if it looks a little oozy as you're opening, let me know. I'll give some DDAVP because of their CKD. Or in the situations where it's starting to look a little more oozy, our lab numbers are still looking totally fine. Fibrinogen in particular is usually the first one to change, but it's still looking fine. I will then empirically give desmopressin. What you have to be careful of is that it does cause hypotension if infused, severe hypotension if infused too quickly. So those doses I mentioned on the slide, you want to give that over about 20 minutes. The second question, you're right, the neural monitoring, it's actually what that twitching is from. Everybody thinks it's the MEPs. It's actually what they're monitoring is SSEPs when that's happening. They're stimulating a mixed motor sensory nerve. The patient's not paralyzed. And so you see that twitching. The signal to noise ratio is very small. They're having to do it over and over again. And therefore, that does put a lot of strain on on all of our catheters, including IVs. For IVs, I make sure that whole catheter has gone in. You're not fishing around and half of it's in, half of it's out. So that could very well infiltrate during the case. For arterial lines, we fortunately don't seem to have that much problem with it. The surgeons know whenever I can have the arms out, I will take the arms out. If it seems that you can sometimes kind of tell ahead of time if that line's starting to get stressed, either the waveform you're having to flush a lot or it's getting harder to draw off of. If we're not having, hopefully we're not having real oxygenation issues, I may switch to sending some of our labs drawing off of a peripheral IV just to stress that line less. But every now and then, unfortunately, I'm under the drapes putting in a new arterial line, which is not easy. And then my go-to is dorsalis pedis because that's, out of the way, but nobody wants to be doing that during their day.
Yeah, we've been trying to use ClearSight, the non-invasive, for rescue, just because, it fails so much. Yeah, thank you.
I think that is our time limit. I think there's another lecture to come in here. So thank you very much.